Joining us today, Dr. J. Bhattacharya. This is our third session during the plague with Dr. Bhattacharya. Early on, he told us what to expect. In our second session with him, he reported on a study that he had just conducted in Santa Clara County. Back with us today, by popular demand, you are, Jay, I have to say, one of our more popular guests. Yes, it beats me too. Today, Jay is going to be telling us about a third study, and an especially interesting study that he has conducted with the Major League Baseball organization. Dr. Jay Bhattacharya and the MLB on Uncommon Knowledge with Peter Robinson in this special Plague Time edition. Welcome, everybody. And Jay, thanks for making time once again.
My pleasure, Peter.
Okay. You've conducted 3 studies. Let's start with the one that's just about to become public, your study of the Major League Baseball organization. How did this come about? How did you conduct it? Just give us a layman's overview of the study itself.
Sure. So it's similar in some sense to the other studies in that I'm looking for antibody prevalence in a population. It just so happens this population is a very unique population. It's the set of employees who work for Major League Baseball and the teams around the country, the Major League teams around the country. How did it come about? The way that the other studies came about actually was through, in some sense, indirectly through Major League Baseball. A gentleman named Dan Eichner reached out to me, and he offered me and my colleagues 15,000 of these test kits to check for antibodies. He said, use them for population health, just for free. I mean, just a very generous man. He works very routinely with Major League Baseball on all kinds of other sort of lab-related things. He introduced us to the Major League, the folks in New York, and they basically very readily agreed to let us run a study in all of their employees, mostly not athletes actually. It's just regular Major League Baseball employees and some of their family members.
So these are the people who handle the accounting, who handle the catering services, who handle press relations, figure out the television contracts, that sort of thing. The people who are in the stadium office, not down on the field or in the dugout. Is that correct overall?
Yeah. I mean, I think there may be some coaches, but for the most part, it's exactly who you said. I mean, it's people who just they work for an organization. Just so happens it's Major League Baseball.
Right. And so. If I want to distinguish between, you say you were looking for antibodies, and that is a different kind of test from the kinds of tests that we saw earlier on in the crisis, which were exclusively PCR, polymerase chain reaction tests, which simply identified whether you were sick at that moment or not. Your serological tests, which search for antibodies, say whether you are sick at that moment or have been sick in the past. Excuse me, not even sick, but have contracted the virus in the past and perhaps even cleared it, so you're no longer sick. Is that right?
Have you been paying attention to me, Peter? Is that what's happened?
This is the third time we're discussing this on camera, exactly, Jay, right, and you've explained it to me over coffee about 5 times in addition, so I finally have it. All right.
Yeah, we're looking for antibodies, and as you say, we're looking for evidence of current or past infection with the antibodies. If I use the PCR test, I would just get how many people currently have the virus right now, which is interesting, but not. It's not as. I mean, to me, it's more interesting to know how many people already had the virus, so we can figure out how far along the epidemic we are.
Right, and the second aspect of this test. When you conducted your first serological test here in Santa Clara County, as I understand it, it was either the first or one of the very first serological tests. They took longer to develop than the PCR test. And now several dozen of these tests have been conducted here, there, and everywhere. This MLB test is the first test that gets us pinpoints across the map. We get some kind of feel for what's taking place across the nation. Is that correct?
Yeah, that's correct. I mean, I mean, I wouldn't say it's nationally representative. That's not right, because the MLB population, even though employees are a unique population, but it is a population nationwide scope, and it's a peek, as you say, into what the disease is doing all across the country in one go.
All right, and you mentioned when we talked about this the other day, you wouldn't tell me much because you hadn't published the results yet. But you mentioned that you consider it almost entirely bad news. Well, so give us the results and tell us why, or were you just feeling blue at that moment?
I might have been feeling blue. I mean, Well, I'll tell you the results, and you can
All right.
decide if it's good or bad news.
All right.
So the first main line result is that the prevalence is 0.7% of the population of the MLB employees. 0.7%. 7 in 1,000 have had evidence of the virus, infected with the virus. Now that's much lower than we found in Santa Clara County, which is about 3%. So
Yes.
30 in 1,000, and in LA County about 4%, about 40 in 1,000. So it's very clearly the case that this is a different population, which has been exposed less to the virus than sort of the populations at large that we found in Santa Clara and LA. As you say, a lot of other studies actually now have been done in the United States and elsewhere. Again, these serologic studies, one in Miami-Dade that found about 3%, just like Santa Clara, another in New York, which found about 25%, New York City and 25%, upstate New York about 3%, Telluride, Colorado about 1 or 2%, and around the world they found numbers ranging from 3% to as high as 30%, I think.
So your numbers are low. The MLB study comes in with low numbers, but in general, aside from New York is an outlier. Everywhere else you test, you get 3%, 4%, 2%, low single digits. New York pops up to double digits. But
Italy
also
singular.
Sorry?
Like the northern part of Italy also pops up higher.
Right.
And some parts of Germany. Yeah, I mean, but yeah, a lot of places we're getting, single digits exactly.
All right. So let me ask, why would the MLB population be 0.7 when in some cases we have data on the surrounding population? New York, certainly, they're the Mets and the Yankees, and what were those results?
They were like 3% in the MLB population and 25% in the surrounding. Now, I think, and actually that's true in Santa Clara too. So, the Giants were 0.
Were they really?
Yeah, 0%. The Angels, I think, in Los Angeles were the highest, about 3.3%, still lower than the surrounding LA County. I mean, of course, they're not in LA County, but that's the closest. Dodgers were also below LA County. I mean, I think so that points to a couple of things that are, I think, really important. So first of all, this is a working age population, and it's an organization that has implemented a lot of very actively implemented measures to try to control the spread of the disease. They've promulgated hand washing protocols. They put in place. They've complied with stay-at-home orders. They put in the social distancing when they are sort of have to be in a place where they're at work. They shut down spring training early. I mean, they've worked very hard to control the spread, and that's in one sense that means that is good news, right? That's been very effective in controlling the spread in their population. The second thing is that we saw this in Santa Clara and LA. I think we're starting to see this nationwide. There's a steep socioeconomic status gradient in who has been exposed to this disease. Meaning that poorer people are much more likely to have had the disease than people who have jobs, who have regular employment. And so we're kind of seeing that in the MLB population. The MLB employee population, they have regular jobs, and their prevalence is lower.
So these are the people you tested, and the Yankees organization. The people you tested work in the office complex attached to the stadium, and then they get in their cars and they drive home to nice suburbs in New Jersey, and they don't go home to the Bronx, the surrounding population. As I recall, the Bronx is one of the higher, within New York, the Bronx is one of the more infected areas. Yeah. So these are pretty good jobs, and these would be middle class to upper middle class people you tested. And it's good in a time of plague to be middle class or upper middle class.
I mean, we did have a few like concession workers and poor people, but it was mixed success getting those kinds of folks in, because they tended to be part-time employees as opposed to full-time employees. But yeah, I think that generally what you said is exactly right. I mean, I think we're sort of in the MLB population, we're seeing a peak at that socioeconomic status gradient that we saw very clearly in the Santa Clara numbers and the LA numbers.
So, Jay, the one piece of bad news is almost ethical rather than medical, meaning poor people get hit harder. This is not something we like in America, but that just seems to be what your study is demonstrating. But another piece of bad news is medical. More than 99% of the MLB employees have not been infected by the virus yet.
Yeah.
That means this virus has a long way to go. Here we are 2 months into this lockdown. Everybody's just had it. The economy is down 4 or 5%. 14% of Americans are unemployed. People have had it. And if we end the lockdown, whether we end the lockdown or not, this virus has a long way to go. Is that true?
That's absolutely true. I mean, the epidemic is very far from over. The lockdown, as I said, from in the MLB evidence and other places, has successfully slowed the spread of it. But that means that once we lift it, it's going to spread. And now people talk about second waves. I mean, we don't know if the virus is seasonal or not. The second wave is, the idea is it's premised on that maybe it's seasonal. So in the summer, it'll slow down in the spread just by itself. But it might not. I mean, it might just start growing after we lift the lockdowns. That is, I think, the main argument in favor of a lockdown.
As I say, we've been locked down for a couple of months now. And in my own mind, I'm still unclear what our leaders, Donald Trump, Andrew Cuomo, or our own governor, Gavin Newsom, what the rationale for the lockdown was and what it is now. There seem to be two rationales. One is we make sure that our medical facilities don't get overwhelmed. That is to say, people don't, this was the concern at the very beginning, that emergency rooms would be swamped. We'd have people choking to death in hallways because there weren't enough ventilators and so forth. That's over. I think there may have been a couple of hospitals in New York, I believe the Bronx and the Queens, where for a while, but even then it only lasted a week or 10 days, the medical facilities really were under pressure. But even in New York, they didn't use the overflow capacity in the Javits Center. The hospital ship wasn't used. So if the purpose of the lockdown was to make sure we didn't overwhelm our medical facilities, it's done. We succeeded, right?
No, that is correct. In fact, we have quite the opposite problem now, that there are hospital systems around the country that are going bankrupt because they had to shut down elective surgeries, all kinds of other services that they normally provide. In fact, a lot of the money, or a large chunk of the money that's been on the bailout is going to hospital systems, actually, just to make sure that we still have hospitals left in this country after the lockdown.
All right. And the other rationale, which I guess the politicians who make this argument or imply this argument just don't know any better. The other rationale is we're going to keep you all locked up until we get this thing licked. But I do think, just in casual conversation, that's in the backs of people's minds. Once the lockdown ends, the lockdown will end when there's no more danger. But that's not possible, is what you seem to be saying.
No. I mean, I think the way you formulated it is exactly right. I think in the back of people's heads is this idea that somehow we can eradicate the disease if we just stay locked down. That is not possible, right? It's the serologic evidence, and even the MLB study suggests this, that suggests that the epidemic's too widespread to eradicate. It spreads via asymptomatic contact, like people who don't have very many symptoms, just even mild cold symptoms can spread the thing. They're not going to show up for testing. They're not going to show up in a hospital. They won't go to a doctor. You won't know that they're spreading the disease. I mean, just in LA County alone, there's the numbers suggest 400,000 plus people have the disease. It's not possible to eradicate it with a lockdown. And so I think we have to come to terms with that. I think. So
can I, on this question of eradication, I just want to, the counterexample, the disease that we think we could eradicate, for example, I'm just asking if this is correct, if this is the right way to think about it. Ebola. You know who has Ebola because it's very dramatic, bleeding from all sorts of orifices and just horrible. Also not terribly infectious once people realize what's going on because it's so disgusting. People keep their distance automatically. And in each Ebola outbreak, of which I guess there have been several in the last decade or so, I think all limited to Africa, but you can count the number of victims. You can keep people away from them, and then you can just wait until those victims either die. Alas, with Ebola, I think at least half of them did die, or recover, and then it's all over, correct? Roughly?
Yeah, I mean, that's the strategy that works with diseases like that. It's called, you test, you contact trace, so you figure out who they were in touch with. You go test those people, and until you've identified all the people in their social circle that have had the disease, and you isolate them, you quarantine them so they don't infect anybody else. That works fine when you have a disease with a very limited number of people who've been infected, and where you don't get a lot of spread via people who don't show that many symptoms. You just basically, if you have the disease, it's very clearly evident that you have it. You're likely to seek medical attention for it. A disease like this, where we've seen a very large number of the people don't have very many symptoms and yet can spread it, this kind of strategy will not work. This strategy is doomed to fail. In fact, it's also going to be counterproductive to do a strategy like this. I was just looking at the news from Ventura County. Apparently, they decided to do contact tracing. Governor Newsom just announced he's going to raise essentially an army of contact tracers. If you're found positive, they'll quarantine you, forcibly quarantine you. Right. So, what are the incentive effects of this? People are going to say, "I don't want to be tested." Like, right. What if I end up positive?
Right. All right. We can't eradicate the disease. Can you just take me through then two concepts? Just explain the concepts, and then, if you would, explain how they apply to the current situation. I have to say, I've heard the phrase herd immunity more times in the last few weeks than ever before in my life. And I don't quite know what it means. It's talking about human beings as if they were sheep, I suppose. How many people have to get infected before you get herd immunity? And then the other thing is, you use the phrase yourself. Another phrase we've heard over and over is running its course. The virus will run its course. Viruses do somehow or other. So just explain those two concepts.
Sure. I want to be a little bit careful here because there's still an active debate among immunologists about the extent to which you actually get immunity after you've been infected, how complete that immunity is and how long it lasts. So there's still questions that left to be answered. But let's just take a tip, like just a virus, not necessarily COVID-19. I mean, typically what you get from a virus is immunity, right? From a viral infection, you get antibodies that protect you against future infections, right? So that's the whole point of vaccines, is to produce those antibodies without actually being infected with the virus. Now, if a sufficiently large fraction of the population has these antibodies where they're protected, well, okay, so just imagine two people interacting randomly in a population. If most of the people have these antibodies, then for sure, no matter what, you're not going to be able to, that random interaction isn't going to result in the virus spreading from one person to the next. So herd immunity is a theoretical idea that says above a certain fraction of the population, it's very unlikely that you're going to contract the virus from interactions with other people.
And is there a standard fraction that is used? Do we say it's a rule of thumb, a simple heuristic? Once you get to 30% or 40%, you're okay?
I mean, it varies from virus to virus, and it varies on how infectious the thing happens to be. So there's a lot of like variables that go into what fraction that is. I mean, like, just if I had to pick a number, I'd say 70%, 80% of the population. But it could be more. It could be more. It could be less, depending on a whole bunch of variables that we don't yet know in the case of of SARS-CoV-2.
But whatever it is, whatever that number is to achieve herd immunity, it is way more than the 20% we see even at the highest infection levels in New York, and it is way, way more than the 0.7% that your study has just picked up among the middle and upper middle class workers of the Major League Baseball Association.
Yeah.
So we cannot eradicate this disease. It's way too late for that. And we are not even close to herd immunity. Is that correct?
That is correct.
Well, you're just full of good cheer today.
I told you, Peter, there was going to be bad news. I mean, I think 0.7 is a success in one sense, right? I mean, we've paid costs for the lockdown. and that lockdown has produced slow spread. In that sense, we've achieved in what we set out to do with the lockdown.
Okay, hold on right there, Buster, because my question to you is, was it the lockdown that achieved slow spread? If it was the lockdown that achieved a slow spread, why is Sweden, which did not lock down? Now, in fairness to the argument, Swedish people, they encouraged people to engage in social distancing. Apparently, hotel vacancy shot up. Swedes stopped traveling on air. People voluntarily engaged in a lot of the measures that we engage in, but the Swedes kept the economy open. They kept their schools open. It's just an astounding thing that in the United States and the United Kingdom in particular, I've been following Britain a little bit, in the First and Second World Wars, Second World War, this is staggering, the Germans were bombing Britain in the Second World War, and they kept the schools open. They kept the children in school. Now, they were shipped out of London, some of them, but they kept the schools open. In this crisis, schools have been shut down. So are you sure it was the lockdown that slowed the spread?
I mean, the lockdown almost certainly slowed the spread. I mean, even in Sweden, there's
that beautiful question. You're just going to bat it aside like that?
I mean, it couldn't not slow the spread. Now, what you're saying is that there are private efforts that also slow the spread in the absence of formal requirements to lock down or close schools or and I completely agree with that. In fact, that's one of the major problems with the disease models is that they pretend that if in the absence of formal lockdown that people wouldn't engage in social distancing or hand washing or whatnot I think that means that they tend to overestimate the benefits of the lockdown. In that sense, I completely agree with you. But the marginal effect of locking down formally is to reduce the social interactions that we normally would do, even when we face the threat of a disease like COVID-19, right? So, I think these legal impositions have their effect, and we have to give them their due. Not as much as people think, because as you say, there's the private efforts that would have happened anyways, but still they do have their effect. And you can see that in Swedish numbers, right? It has spread more within Sweden than it has in Norway. There's more deaths in Sweden to date from COVID-19 than Norway. But
do we know that the Swedes are not simply getting through it more quickly? That the Norwegians will have the same death rate in the end?
That's the thing. It's not that the lockdowns, people look at the lockdowns, they think things like, okay, the death rates have to go down for 14 days in a row and then we can lift the lockdowns, right? But if I'm right that the lockdowns are effective, you lift the lockdown, then it just starts growing again. Okay. Right? So it's not that the lockdowns are not a mechanism for disease eradication. All right. They're not a mechanism of disease eradication. They will never eradicate a disease. It'll only delay when the disease happens, now or later. You pay the cost now or you pay it later.
All right. So COVID is like Wimpy in Popeye. I will gladly pay you on Thursday for a hamburger today. All right.
I thought it was Tuesday, but
Tuesday could be. There I won't quibble with. There I will defer to your superior learning. Jay, let me ask you 2 or 3 questions that are just what do we know now questions. The weather. Here in Northern California, the last couple of days it's been in the 80s. That's dramatically different from when the lockdown started. It was still gray, rainy, cold. What do we know about warming temperatures?
We don't know. We don't know for sure. I think there's a hypothesis going around that like some other viruses, it's seasonal, and so it'll become more dormant and the spread will be slower during the summer.
But we don't know why. We don't know for certain that it's warmer temperatures that slow it.
Yeah, I think why could be just the virus doesn't, it's unstable in sunlight, or there could be all kinds of reasons why. But we don't know for certain that's true in this case. Now there's some evidence from Australia, for instance. It hasn't spread as widely in Australia, I think, as people thought, because they were in their right. Exactly. When it was spreading. So,
Jay, what do we know about transmission outdoors versus transmission indoors?
Seems like indoors is where it's happening, where most of the transmission happens. So, for instance, in New York, a lot of the spread was in nursing homes in Wuhan and in Italy, in hospitals. Actually, in Italy, also in nursing homes. You need it seems like you need to have some extended contact with people who are positive in a setting indoors for it to spread. Now, that's not to say it can't spread outdoors, but it looks like from the evidence that I've seen, mostly it's indoor spread.
All right. Transmission from children to others. We learned very quickly that children didn't seem to come down with, they didn't become symptomatic, but is there beginning to be evidence now about transmission from children to others?
So there's this absolutely fascinating study out of Iceland. This company, I think Decode Genetics is called. They sequenced every single virus they could find among people in Iceland. I think Iceland, they've actually done PCR tests on 12 or like almost 15% of their population. And every positive person they got, they took the virus and they sequenced it, and they looked for mutations. And from these mutation patterns, you can figure out who got the virus from whom.
I see.
So, for instance, they figured out that a lot of the virus inside Iceland came from the UK, because that's where the matched the mutation patterns in the UK, and they also from like some ski resort towns in Germany or Austria or something. Anyway, so one of the main things they found was that there wasn't a single instance where they could show that the virus had gone from a child to an adult. It was always the other way around.
Always the other way.
Yeah, I guess I should be careful. They said it was not from a child to a parent. No instances of that. It's always the other way around.
All right. What do we know about the death rates? We talked earlier when you were about to conduct your first test here in Santa Clara County that the fatality rate was almost meaningless because we didn't know anything about the denominator, how many people had been infected. But I've seen so many stories. Again, I'm just a layman. I'm reading the newspaper and I'm checking it with a professional now. I've seen so many stories that death certificates, there's at least cause for concern that death certificates are overstating deaths from COVID-19. Do we know anything about that? Is it all purely anecdotal?
I mean, I think that death certificate data, they're filled out by doctors who have to make a difficult call, right? So you have a patient, I'll just take an example that had nothing to do with COVID-19, just to give you an example of the difficulties, right? So you take a patient with diabetes, they have a heart attack. The heart attack causes, because of the diabetes, their arteries clog up in their heart. The heart attack causes their heart to fail, which then causes their lungs to fill up with fluid. Then they get pneumonia and they die of the pneumonia.
Okay.
What should I write down for the cause of death there? Diabetes, heart disease, pneumonia. I mean, it could be a lot of things I could write down there. So people are making difficult calls when they fill out death certificates. I don't want to second guess that. I'm much more interested in the denominator, right? Even with whatever's happening in the numerator, what we found in Santa Clara is that it was somewhere between 0.1 and 0.2%, 1 in 1,000 and 2 in 1,000 risk of death. Same thing in LA County. Actually, they found the same thing in Miami-Dade. They found, I think in Germany, they found somewhere between 0.25 and 0.4%, again, 2 in 1,000 to 4 in 1,000. In New York City, they found about 5 in 1,000. So it's basically consistent worldwide, somewhere between 1 in 1,000 and 5 in 1,000 in all of these serologic studies worldwide. And by the MLB, by the way, it was 0. There was no deaths in the MLB population, despite the 0.7%, 0% mortality.
I see. Jake, another one of these questions when I'm just asking for a simple education. Distinguish, if you would, between a vaccine and therapies.
Yeah, so a vaccine, what it does is it injects in you certain parts of the virus that don't actually make you sick.
Right.
And that induces your body to produce antibodies that then, if you're exposed to the virus, would be neutralized by the antibodies. Right? So your body has now produced its own, essentially, defense system in reaction to the thing that you're injected with.
So it is of the nature of a vaccine. This is the bit I care about. It's the nature of the vaccine that it very substantially just solves the problem.
Yeah.
But those are hard to develop?
Very difficult to develop. There aren't any vaccines for human coronaviruses. So, there's six, I think, I don't exactly know the number, something like 5 or 6 coronaviruses that infect humans, and we don't have a single vaccine for any of them.
Wow. So this notion, apart from anything else, the idea that we could continue the lockdown until a vaccine is developed is just ridiculous. That's preposterous.
Well, I hope I'm wrong. Maybe like there's a tremendous effort worldwide to try to develop a vaccine for SARS-CoV-2. And I hope that it succeeds. Should we continue the lockdown until it succeeds? Well, we don't have a vaccine for HIV. We don't have a vaccine for any of the coronaviruses. It's a very difficult task to develop a vaccine. There's a lot of very bright minds working on it, but should we basically
It's unpredictable. It's unpredictable. It's not like building a building where we've built a lot of buildings in downtown Manhattan, 60 stories, West Side. Yeah, okay, here's the budget, here's the time, and within 10% of each, we'll bring it in. You can't do that with a vaccine. It's just utterly open-ended. Mm-hmm. Is that all right? And do we have evidence now that we have any truly useful therapies for treating the thing?
Okay, so
the vaccine solves the problem, and the therapy addresses the problem after you're already sick, right?
Right. So one of the things we learned from the serologic studies is that there's a very wide range of presentations, right? So there's the mild illness that, or almost no symptoms, looks like a cold kind of version of it. And then there's these like absolutely deadly viral pneumonia that we're reading in papers about. The focus of therapeutic effort is to either prevent once you get infected from people getting the very, very severe presentations, or if you do get the severe presentations, to make sure you don't die from it, so you can get essentially healed despite having had the severe presentation. So those are the two kinds of distinctions I make for therapeutics. There's been some advances. So like there's a company up the street called Gilead that's produced a drug, actually an older drug that they tried out in here called
Remdesivir.
Remdesivir. You got it better. Okay, wow. Peter, they should give you an MD. Okay, so that seems to have some effect on people who have these like severe pneumonias, but they haven't checked to see if it reduces mortality yet. They've done some randomized studies. It looks promising, but it's not. I don't think anyone thinks of it as it solved the problem, right?
Okay. So Jay. So now I'm going to play some composite character. I'm going to be one part Gavin Newsom and one part Andrew Cuomo, and heaven help me, one part Donald J. Trump. And I'm going to say, Doctor, fat lot of use you've been to me so far. I've got this lockdown going on. Huge numbers of people are unemployed. Even those who can work at home successfully and who can work at home and continue to receive their paycheck have had it about up to here. Schools are closed. Goodness knows how kids who are high school juniors this year are going to apply to colleges next year when their junior year grades are ambiguous and they're not taking the SAT. It's going to take, if we ended the lockdown tomorrow, it would take months for us to recover and to get back to anything that feels like normal. And here's what you're telling me, Doctor. You're telling me that we have no idea when or if a vaccine will be developed. You're telling me that we have only very preliminary information about any therapies that might prove truly useful. You're telling me that although the fatality runs in the range of 1 to 5 in 1,000, which sounds pretty low. Well, I'm a working politician, and I know the way the network effect works among people. 1 to 5 in 1,000 is enough that when one of those people dies, 300-400 will have heard of it, will have known the person, will have known the person's family. That is plenty to scare people, really scare people, and understandably so. And you're telling me that once this lockdown ends, this virus is still just getting started infecting our people. What in the hell do you want me to do?
What I tell you is there is no safe option.
Oh, thank you. All right,
That
go
is what
ahead.
I'm
Give
telling
us.
you. So if you think that having the lockdown will provide you safety, you're mistaken. Because the problem is that this lockdown has had enormous negative effects on the health of people in the United States and worldwide. We talked about the first time the way I was talking about it is lives for lives. I still believe that. There have been people who have delayed their chemotherapy as a result of the lockdown. They've had heart attacks and not gone to the doctor. They've had I just saw a report that estimating, nearly 75,000 people additional will have committed suicide or as a result of the lockdown. I mean, for these deaths of despair over the next year.
Worldwide or
no, U.S.
So how many people have died of the coronavirus so far? What's the top estimate? 30,000?
Oh, I didn't look at the number today, but I think 70,000 up to now.
70,000. So as many people have killed themselves as have died.
Well, I mean, I think that's a forecast. So that's not.
I see. All right.
But I mean, but you get the point. I mean, that happened during the Great Recession. There was these deaths of despair. That's going to come back in spades when we have a GDP collapse of the sort that we're seeing, an unemployment rate that we haven't seen since the Great Depression. And that's just the United States. Worldwide, there is already evidence of resurgence of diseases that we thought we had a handle on. 1.4 million cases of tuberculosis not treated in India. Starvation of children.
With that 1.4 million cases of tuberculosis in India.
Yeah.
That as a result of COVID, as a result of the
lockdowns. The lockdown. I mean, it's basically people sparing the hospital systems to try to be able to treat COVID patients. I mean, and shutdown orders that make it difficult for people to travel to the clinics to get the. I mean, for tuberculosis, you need basically regular antibiotic treatment for very, very long time.
So in a place such as India, you impose a lockdown, and you're pushing the entire population into a time machine. Their healthcare regresses a century.
Yeah, I mean, I think that's not just true in India. That's true in every country on earth. Especially the poor people in every country on earth will suffer from this global economic collapse that essentially we've caused. I mean, partly it's due to COVID, but it's partly also the response of governments around the world to shut down our economies. There is no safe option here. You either face the problems that have to do with lifting the lockdown and COVID, or you face the problems having to do with the economic collapse that we've caused as a result of trying to deal with COVID.
All right.
So no matter what choice you make, Peter, you are in some sense going to be on the hook.
Okay, so again, I'm playing a composite of several politicians, and I'm a working politician. Here's my calculation. I'm going to keep the shutdown going until I figure out a way whereby whatever happens next, I don't get blamed. Is that a good calculation? Is that useful?
I mean, I understand the incentives. I think what I would like to see is actual leadership.
Okay, so enough of my playing Gavin Newsom and Andrew Cuomo and Donald Trump. You're the governor of California. You're the governor of New York. You're the president of the United States. What do you do? Do you peel up a corner of the lockdown? What do you do, Jay?
Well, I think there's a lot that we've learned about the virus that could help here.
All
so
right.
One is, I think we know for certain that there's certain groups that are very, very high at risk when they get the disease.
Old and sick.
Yes. So we have to work very hard to protect people when we start lifting the lockdown who fit that description, especially the places where they live. Right. The fact that such a large fraction of the deaths have occurred in nursing homes is a clue that that's where we basically should be taking action to protect people. Quarantining, basically making the nursing homes much safer is going to be a huge priority as we lift the lockdown up. I think there's other kinds of things we've learned about. So we're much better with ventilator protocols than we were at the beginning of the crisis. I think that's a concrete improvement that's already starting to happen around the country and around the world. So I think there's a lot potentially we can do using the lessons we've learned over the last couple of months to improve things as we lift the lockdown.
Jay, you and I are now, forget about democracy. You and I are now co-emperors.
Peter, this is more and more uncomfortable. First I'm governor, now I'm emperor.
Now you're emperor. Well, the meaning, if we could get anything done we wanted to do, what would we do? And so I'm the budget emperor, and I'll let you be the guy who decides. You be the decision emperor. But the budget emperor says, well, the Fed has already made available 2.2 trillion. Who knows? At that stage, the numbers are almost meaningless, but it's made available well over $2 trillion in new debt facilities. And Congress has already enacted 2.3 trillion in various forms of aid. 40% of it wasted is my view, but still, or maybe 60%, but still some of it goes for unemployment. All right. So what you're saying is, whatever we need to do to protect the people most at risk is going to cost a tiny fraction of what we've already spent for this lockdown. By the way, on top of the money going out, you have to take into account a 17, 18 trillion dollar economy, which has shrunk 5% in the last couple of months. So that's some X trillion dollars. The sums are just vast. So I guess what I'm saying is, take 100 billion and do anything you want with it. Would that help? Could you fix things pretty substantially with 100 billion? Nursing homes, older people.
Yeah, I mean, I think those things we can do for sure. I mean, I don't think it would cost 100 billion. I don't know how much it would cost. But
okay. Well, my point is actually, if we're being sensible, we can do stuff that doesn't cost much. That's my point. Is that right?
Yeah, that's right. The other thing is, I think we actually need we need to better understand who actually is at risk. I mean, it's not all old people that are at risk. That's not right. I think again, for not that expensive, we could better learn who's at risk and then focus our attention on providing support for those folks. Right. So, I mean, I don't know exactly what that would look like. So I'm a little hesitant to answer this, Peter, because this is why I'm not emperor. Like, you have to actually operationalize that idea.
Okay. So here's a question I have for you then. Again, this is just a layman fumbling around, but it occurred to me to think of the COVID-19 as two viruses, even as back at the turn of the 20th century, physicists began to think of light as both waveform and discrete particles. Two contradictory concepts, and yet it seems that both were true. And here's what I mean. In a large majority of cases, COVID-19 is a bad flu, maybe even not a bad flu. Quite a few people are totally asymptomatic. But in some unknown number of cases, smaller, much smaller, but still significant, it is much worse than the flu. So we have an unusually vigorous 55-year-old who comes this close to losing his life, and he's the Prime Minister of the United Kingdom. That's not the flu. And if we can figure out what it is about these special cases, those are the cases that scare everybody witless, understandably so, right? Now, have I framed a question that's scientifically pursuable?
Yeah. I mean, I think the way I would say that is, I think we have to characterize who's most at risk. What clinical characteristics, what demographic characteristics put you at highest risk for the severe presentation of the virus? That's an answerable question. I mean, there may be things we don't know, but we can take a good stab at it already, I think. I think that should be the first priority for epidemiologists and clinicians to try to figure out who's at most risk. And then once we have that answer to that, we can do more than just protect the nursing homes, right? We can tell people, okay, you have a set of characteristics that puts you at risk if you were to get infected. You wear a mask, you work to protect yourself from exposure, consider carefully about working from home. Whereas Peter, you don't fit the profile of someone that's really, really high risk. You still have some risk. I mean, no life without risk. But you're more likely to be down over here than over here if you get it. you make your decisions about how you want to live your life.
Okay. Last couple of questions. What about testing? Some people, Paul Romer, Nobel Prize winner, a former colleague here at Stanford, now at NYU, but he's calling for vast numbers of tests, tens of millions of tests, testing becoming a regular part of everyone's life. How do we do? Is that reasonable? Would it be useful? Where do you stand? I mean, you're protesting because we're talking about a new test that you've conducted.
Well, I mean, the question is like, how do you use the tests, and what does it mean for your life as a result of having that? So the test, I think that the Paul Romer is calling for are these PCR tests. They test whether you actively have the virus, as we talked about several times. So you have the virus. You don't have the virus now, Peter. Okay, I test you today. You're free to come to work. Do I test you tomorrow? Because you might have gotten the virus between today and tomorrow. Do I test you the next day? I think in order to be effective, I mean, you don't have to do it that frequently. Maybe you do it once a week.
But it's a lot.
Antibody positive. I mean, I think you'd have to have it. It really would have to become a regular part of your life, and not just to come to work, but to go to anywhere, right? If you wanted to do that, it'd be billions and billions of tests all the time. They're not. I mean, the other problem with a lot of those tests are most of the PCR tests take 2 days to come back. Now there are these point of care ones. I think clever people have been working to build a testing regimen that minimizes the probability of your being sick when you go to work or an environment that where you want to interact, using a combination of antibody tests and PCR tests. I assume that clever people are going to be able to come up with that kind of regimen. The question to me is, we normally have thought that health privacy was a good idea. Your DNA now is in the hands of, you go to a restaurant, you do the swab, now the DNA, the restaurant now owns your DNA. You go, basically anywhere you go, you're going to get tested. I think that's possible. Again, some very, very clever people have designed mechanisms to do that, but I think that would result in a fundamental change in how we view, a fundamental change in American life. I guess I'll just leave it at that. I personally don't want that, but I can see why people might, because they trade that for some safety.
All right. A couple of last questions. Jay, so you're in favor of lifting the lockdown, and you have to answer an accusation of callousness from a former vice president of the United States now running for president, Joe Biden, quote, "No life is worth losing to add one more point to the Dow," close quote. You, Jay Bhattacharya, are willing to trade lives for dollars. How do you answer that?
Actually, I should be careful. I'm in favor of the lockdowns being lifted where it makes sense to lift them, right? So where we've run the numbers and we say, okay, it's not going to overwhelm systems or whatnot. But let's take that as given, right? So we've run the numbers.
On your reckoning, that's most of the United States now.
That's probably most of the United States, but we should run the numbers first just to be sure it's safe. We don't have serologic studies everywhere, so I don't know what the numbers are most of the country. Anyway, so let's take as given that I'm in favor of the lockdown being lifted in a certain area, right? The way I'd answer Mr. Biden is I would say, look, you've mischaracterized the other side, right? Are you in favor of 75,000 people killing themselves extra as a result of the lockdown? Are you in favor of starving tens of millions of children across the earth? I don't think an accusation of callousness. There's morality on both sides of this argument, is what I'm trying to say, and it's extremely misleading to say that only people who want to lift lockdowns are people who are greedy, focused on money. That's just not right. The fact is that their lives is going to be lost on both sides of that policy, and both sets of lives count in the calculus.
All right. Jay, penultimate question, and then we get to the last question. Here's the penultimate question. The second time we talked, you discussed your study in Santa Clara County. And within 48 hours of your releasing that study, within certain niches of the internet, there was an explosion of statistical challenges, which I'm perfectly happy to admit I couldn't even begin to follow. Miscalculation of false negatives or false positives, something like that. Can you just, you have explained all the, you've dealt with these arguments, but I just, for viewers who saw that and maybe wondering what's going on, can you tell us where viewers can go, and then we'll link to it when we put up the show.
Sure. So we have an answer to all of. I mean, I guess I was a Twitter celebrity for a little while as the statistical Twitter model.
Infamous, not famous, but infamous.
Infamous, yes. Right? That's, I've been told that by my kids. So I think let me characterize the basic argument. We're using a test that has some rate of false positives, meaning that if you're truly antibody negative, some of the time, actually it turns out to be about 0.5% of the time, meaning
1/2 of 1%.
Right. It'll show up as positive.
Right.
Okay, suppose that the prevalence is actually in the population 0.3%. Well, that means I can't rule out that all of those 0.3% were actually zero.
Right. Okay.
Right. So essentially, that was the argument they were making.
The test isn't fine-grained enough to pick it up with certainty. All right.
Correct. And so I think that's in essence the kind of argument they were making. Now, there was a variant of that because they're talking about standard errors and a whole bunch of other details that we cover in the response document that are not so important. But that in a nutshell is the argument that people were making. The problem with that argument is that they just got it wrong. Like you can actually, the prevalence in Santa Clara turned out to be about 3%, way more than the 0.5% that we had.
I see.
And even at the base of the stand, like even if you took the worst case of what you thought our test characteristics were, you still were above zero. So I think they just simply got the statistics wrong. It was just just a lot of noise. I think a lot of the why am I Twitter infamous on Twitter? I mean, I think even though I'm not actually on Twitter, I mean, I think a lot of the Twitter critics, what they were arguing is that look, the test kit that we're using is not accurate enough to pick up the prevalence numbers that we saw. That in fact, all of the positives we had could be false positives. But that argument is actually just simply wrong. It's just not true. Even at the bottom of even if you take the worst case for how accurate our test kit is, it's accurate enough to pick up the 3% prevalence we picked up in Santa Clara. It's accurate enough to pick up the 4% we picked up in Los Angeles, and actually it turns out it's accurate enough to pick up even the 0.7% we picked up in the MLB study. And we make that case in a sort of an answer to the critics in that preprint server you can link to.
Okay, terrific. Jay, here's the last question. Should the MLB start the baseball season?
I think they're thinking about how to do that safely. I don't think probably
there is a way to do so safely. You'd advise them if you're careful, you can go ahead.
I mean, no one's asked me that question from the MLB. They're not going to because I'm not hired by them to answer that question. In fact, I didn't get paid by them at all for the study. I think the kinds of thinking that let's leave the MLB aside that I've seen from other sports leagues around the world that are thinking about this is let's do testing to verify the set of athletes and coaches and umpires and whatnot that are there are negative. Essentially isolate them for the whole season while they play games with each other in front of nobody.
Oh, really? Oh.
Yeah.
Oh,
so that's the kind of reopening I think they're thinking about. I mean, I can't speak for the MLB. I don't actually know what the MLB is doing along these lines, but this is again what I've heard from other sports leagues.
Is that overcautious or is that perfectly reasonable?
I think it's reasonable. I mean, I don't think you want to expose fans to this. You don't want to expose athletes to this. To this. I mean, you're asking me what would I do if I were governor? Like, what would I do if I were the
MLB commissioner?
The MLB commissioner. I mean, I would be risk averse about this, but I also would want to seek ways to open the thing up.
Okay, it's not as much fun, buy me some peanuts and Cracker Jacks, that sort of thing.
You can watch it on TV, Peter.
All right. Dr. Jay Bhattacharya, professor of medicine here at Stanford. Thank you for joining us once again.
pleasure. Thank you, Peter.
For the Hoover Institution, Uncommon Knowledge, and Fox Nation, I'm Peter Robinson.